all for coming. Just wanted to welcome everybody. I know that we're all going to be sort of filtering in as time goes on. Thank you. My name is Shoshana Hellman. I'm in charge of the Palliative Care program here at Valley Medical Center. It's my great pleasure to introduce Dr. Andy Billings. I only printed out the first 5 pages of the CV because it was just going to be too much to do with the introductions. But I'll start by saying that he got his medical doctorate degree at Harvard, went on to do residency at UCSF, and then, I love this, in the mid-70s did a fellowship in psychosomatic medicine. I didn't even know such a thing existed. And then a fellowship in adult medicine, and is a Soros Faculty Scholar for the Open Society Institute Project on Death in America, and a senior editor of the Journal of Palliative Medicine. He also received an award for palliative medicine leadership from the American Academy on Hospice and Palliative Medicine. And I'm running out of time to see here. He's written more things than book chapters and articles than I can count. That's all the other pages of the CV that I didn't print. He is currently an instructor in medicine at Harvard and Massachusetts General, Director of Palliative Care Service at Massachusetts General Hospital, and co-director of the Harvard Medical Center for Palliative Care. It's my great pleasure to have him come and speak to us about palliative care in the ICU.
Thank you. I hope if you can't, if you can't hear me, please let me know. The topic that I seized on today is the family meeting, and I'm going to talk about what the family meeting is like in an intensive care unit. I think you'll see that it generalizes to family meetings in other parts of the hospital, but this is a very basic skill of all clinicians, and I say both physicians and nurses, and social workers, and chaplains, and so on. That's particularly prominent in the intensive care unit, but again, I think it occurs in the office, it occurs in the intensive care unit, it occurs in many different settings. And the basis for this discussion comes from a 3-year project that we did in conjunction with 3 other intensive care units, in our case, in the medical intensive care unit, that we call merging cultures of palliative care and intensive care. And people tend to think of them as being sort of at the opposite extremes, but we all felt that a lot of palliative care went on in the intensive care unit. I'll talk about that. And that we were trying to both have great saves in the intensive care unit, but also good deaths. So the family meeting is an essential skill, as I said. How many people here have had some formal teaching about how to do a family meeting? Oh, great. Well, that's the largest percentage I've ever seen. This actually, this teaching began with an intern going into a room with where we were starting a family meeting, and the social worker was at the door, and the intern came in last and sort of turned to the social worker and said, "What do I do?" And we found at least that our interns and residents, while we did a lot of family meetings, they never had a chance to really talk about how to do it. And if you think of it as a communication skill or interpersonal skill, those are really complicated and difficult, at least they are for me. Trying to tune in on what people care about, what's important to them, and what the meaning of facing life-threatening illness is like. And well, my son is a graduate student in physics at Stanford, and he talks about the two-body problem. Or you all remember? I have no idea where this comes from, but the two-body problem in physics, where you're trying to understand all the forces that go on between 2 bodies, and that actually apparently is a soluble problem, electromagnetic. I don't know. But 3-body problem can't be solved. So, and what we're going to talk about today is, a 4-body problem, a 6-body problem, with all these people often, you know, some strangers in the sense that doctors and nurses are often, especially in the intensive care unit, not familiar with the family. And so kind of like a meta message of what I'm going to talk about today is, well, you know, complex skills like this don't get just taught in an hour grand rounds. I'm going to try to give you kind of a roadmap, some things to think about, and we're going to look at a family meeting and try to sort of see what goes well and what doesn't go so well. We're going to kind of practice some skills, or at least we're going to see the family practice some skills. And my sort of meta message is, think of this as a very important skill that you're learning. These are the kind of skills where you talk about 10,000 hours of work to really be able to do it well, like playing chess or being an architect or being never figured out, senior resident maybe, I don't know. But at any rate, a lot of hours. But the people who get good at it, like with chess, the people who kind of reflect on what they're doing, who say, oh, how did that go? And so we're going to do a little of practicing of being reflective. All right, so where am I? This is the context. Just a touch of data. A third of Medicare patients spend time in the ICU in the last 6 months of life. The average is apparently, for the whole population, is something like 2 or 3 days. A lot of them die in the ICU. It's about 20% of deaths. As many as 90% of patients who die in the ICU have orders to withdraw life-sustaining therapy. Now that's an order, by the way, that hardly existed, say, 30, maybe 40 years ago. 40 years ago. It's something that we're learning about in a sense. It's something.
Your microphone fell off.
Did it fall off? Yeah, sounded like it. I heard it plunk to the. So it's a new, culturally, it's a new skill. I mean, 40 years isn't very long. And the thing that I'm going to sort of focus on here is the family is usually the decision maker, the proxy, the healthcare agent in these settings. So I'm going to actually focus on those kinds of discussions where there is no patient, the patient's incapacitated. We might hope they have an advanced care directive, but they rarely do, at least statistically around the United States. And I think even more important, it's very often difficult to really represent what the patient wants in an advanced directive once you get into the situation that you're in. It's hard to predict the future. Okay, now we'll just do this without writing things down yet, just to make it simple. What are your reasons for having a family meeting? I mean, you don't do it with every patient, I assume. So what kind of reasons come to mind? Think about your last meeting. I will give you one other little meta message. Those of you who've taken our course or know about our course and the kind of teaching we do, it's always interactive. You learn a lot more if you talk, if you get involved. You retain much more. Lectures don't work that way. So I want to get you involved. So at least think about your last family meeting. But will somebody say something about his or her last family meeting? Why did you do it in the intensive care unit? Okay, but educationally. Okay, it's a way of informing the family about what's going on.
Clarification of goals.
Okay, goal setting is also very important. Other reasons.
Understand what they understand, trying to get a sense
Okay.
of what they know about the disease and what's going on.
Great, okay, thank you, that'll come up a lot. Other things that you think about?
Discussing prognosis.
Great, okay. And I guess what I would say is, very often, again, we have some observations at our place and elsewhere. Very often, it's not for a good prognosis, right? When people say discussing the prognosis, they're talking about it's a breaking bad news experience. I think this is kind of a simplification, but if everything's going great, why have a family meeting? I mean, you're busy, you've got a lot of other things to do. If the family understands what's going on, if they're on board, if they know the prognosis, if you feel they understand, if they're acting like they understand, why have a family meeting? Please.
Well, first of all, if they're in the ICU, nothing's going great. That's why they're in the ICU.
Okay.
And often, you never get a second chance to make a first impression. So it's always better. My habit in the ICU is that I'd rather meet the families when things are going not so badly, so that when things get worse, they know who I am, and they don't say, look, where were you? How come I'm only seeing you now?
Okay, that's great. I didn't pay him to say that. But, did I do that?
No, by the way, no one can pay me to say anything.
So I was going to write this on the board, but here's just a list that I think is fairly typical. See, I would put conflict resolution way, way up at the top. And it's because, again, there has to be some discordance usually for us to get going to have a family meeting. Is that me? It's not my hearing aid. Why don't I just take this off? If you can't hear me, let me know.
Just all pages.
It's all pages?
Yeah.
Okay, I'll put this back on. Exactly. I'm glad you're all going to that family meeting. I think if you think about them, typically there's something going on that's a conflict. It may be about knowledge, maybe about goals, it may be about understanding. It's usually about bad news and some sort of decision. If everybody's agreeing with what to do, we tend not to do it. This is the part I didn't pay for, in part, but building trust with the family. And if you think about the situations where things go really wrong, trust is often the basic issue. I mean, look, you're working here in a big hospital, and you're dealing with people you've never met before, especially in an ICU. And you're just total strangers to them. And somehow or another, most people, and it's the exceptions in a way we're going to talk about, most people feel like you're good people, you're well-meaning, you're skilled, you're going to do the best that you can by them. And we have that blessing of our professions. But to get back to the paid announcement, the meetings tend to be reactive. And I'm going to present to you very quickly the data that says you should be doing this with all your patients. You're not going to do it with all your patients. I mean, if a 18-year-old diabetic comes in with his third episode of ketoacidosis, and you know he'll be out of there in a day, you're not going to have a family meeting. Though they need, probably won't. Needs one with his primary care physician, but anyway. But the proactive meetings is what I would like you to think about more and more. And there are two kinds that have been described. There are two very important papers on routine prophylactic family meetings. And that means essentially that everybody who comes in the ICU within the first 48 hours, a family meeting is held. And trust and understanding is a good part of that. Though the other part is to get everybody on the same wavelength. And what you say is, listen, if his propofol needs, let's say if his pressor needs go like this, we're in trouble. And if it goes like this, things are going well, or oxygen needs, or so on and so forth. Where you start getting the family to understand what you're looking at, and often the first 48 hours, it's very hard to prognosticate on patients. And we're watching those things just, but you get the family sort of on board. And the second kind that I want to propose is a triggered meeting, and that's where there are another 9 papers that say, if you can have a low threshold for having these meetings, you will have much better outcomes, which I'll describe. But there have been a number of approaches to doing this. There is, one is whether you have a screener. And at one institution, for instance, there's just a nurse who walks around and says, anybody we should see. And that works beautifully. And that's sort of what we did in our medical intensive care unit, except I was one, but it was a physician unit. But what we look for, and again, in different studies, they look for different things. Earliest sign of conflict. I would say when you get a little feeling in your gut that things are not, you don't feel that comfortable with the family meeting. There have been some algorithms like third admission in a year for a patient with heart failure. Certain diagnoses like advanced dementia or anoxic brain injury, you sort of, should trigger it. In one study, they just looked at people where they came in and they thought this person is going to die or might have a good chance of dying, or if they survive, they're going to be at a different level of function. They're going to be nursing home patients or chronic care patients rather than, living happily at home. And then another one, which I think your administrators will just love, is, by the time somebody's been in the intensive care for 2 weeks, 3 weeks, whatever your sort of average length is, there's all kinds of trouble brewing, and they should have had a family meeting then, if not a lot earlier. And those are the 11 studies, which of course you can't follow. And I'm not going to describe to you, but if you want to read the literature, I'll give you a bibliography at the end of the day. And here are the outcomes that have been well demonstrated. Again, 11 studies, all of which showing some array of the same things. Most important, I think, the family feels better and the staff feels better. At least in our ICU, the issue of turnover of nurses and conflict between the nurses and the staff, or between the nurses and the family, or the staff and the physician's family, big deal. So, and where things are going well, care is better also, and outcomes are better. At any rate, improved satisfaction, less conflict, better outcomes for the family. There's a high incidence of PTSD and depression in families surviving a death in the ICU. Resource utilization, less x-rays, less MRIs in the last few weeks of life, less people on ventilators. DNR is put in earlier, and again, for your administrators, particularly, less days in the ICU, less hospital days. None of which, by the way, affected mortality. So it's not like you're giving up on people quicker. In fact, there's going to be one coming out, and there's another study that suggests that people who there's a higher survival rate in people who get palliative care kinds of consultations. Okay, so let's put the screen up, and let's do a role play. Now, everybody here really likes role plays, right? Okay, so a word about role plays. I'll direct this to our thespians here. I'm working on my tennis game. I figure you'd all relate to tennis being California. I'm from California. So I'm working on my tennis game, and my chop is really screwed up. So I'm going to get a bunch of balls, I'm going to go find a backboard, and I'm going to practice my chop. Maybe I'll have videos of my chop, whatever. And then I'm going to get one of those ball machines, and I'm going to, that sends you balls high, low, so on and so forth, and I'm going to work out and get my chop just right. And then I'm going to get a trainer, and I'm going to have him hit me balls, and I'm going to work on my chop, and I'll get more advice from him about what to do with my elbow and that kind of stuff, and my grip. And then I'll go out and play tennis. Anyway, role play is all that stuff before you go out and play tennis. It's a way of practicing, and it's just a game. The nice thing is you can stop it, you can start it, you can be silly about it, which I try to be. And I'd like, what we're going to do is take this case and role play it for a little while. We got lots of time, and we're going to, what I'm going to ask you to do is to watch it carefully, take careful notes, and when we're done, we'll talk about what went well and what didn't go well. Okay? Deal? Great. Okay, so let's have our family and doctor come out here. I'd like the doctor to sit here, and let's have the nurse sit here, and we'll have the husband sit here. The nurse. Oh, okay. You're our husband. And let's see, the sister, and no, the sister should sit here, and the son and daughter can sit there. I usually bring little signs so you can remember who's who. Doctor, nurse, husband, son, daughter, the sister. Okay? And does everybody have the role play? I mean, the case? Everybody have it? Okay. I'll just say briefly, the patient is Mrs. Duncan, so it's Mr. Duncan and so on. And she's 54. She has pancreatic cancer. She's gotten all the standard chemotherapies, and she's actually had a phase 1 trial, and she's doing very poorly. She's losing weight, multiple liver metastases, and she comes in the hospital with abdominal pain, jaundice, prolonged INR, has a GI bleed, she aspirates, she's intubated. It's not good, as somebody said about the ICU. So she's kind of stabilized after 2 days in the ICU, and her GI bleeding stopped, but all her parameters are really lousy. She's requiring pressors, her liver function tests are terrible, her ammonia level is off the roof, she needs 100% oxygen, and when they lighten her up, the daily lightening trial, she doesn't really wake up, but she seems restless, and nobody thinks that she's going to get out of the ICU or be extubated. That's a sort of an important point, I think. The decision about that sort of prognosis is very, very hard. And having taught this to our interns, residents, fellows, and attendings, I can say that it's very hard for our interns and residents, let's say playing the doctor here, to really be very sure and very clear that this patient's going to die. And that's very difficult for those family meetings, because if you don't, I think it needs to be clear here. If I think maybe it's sort of unlikely if you give that sort of message, which often you have to. I mean, I don't mean to, I'm not saying make up a diagnosis, prognosis, but it's very hard to say that with certainty, like in a way because we're training interns and residents and fellows to think about all the other possibilities. And I mean, it's part of the being a good doctor is not to be certain and to think of before somebody dies and to think of all the little things. On the other hand, there are plenty of times that we know it pretty clearly. So that's actually an important, for us what that means is, and we don't do it, but at least theoretically, there needs to be a very good discussion with the attending, where the attending should be present in these discussions so that there's somebody there with a little either gray hair or a senior resident who feels very clear that this is the right thing. Okay, so what we have here is Mr. Duncan, who's a businessman. She's very close to her sister, who's here on this end. She lives far away, but they're very close. And what we're going to discover is that she didn't really talk about dying with her two kids. This one is in college, and he's just about to take his MCAT, and she doesn't want to, to screw him up, and she just wanted to protect her, her children from the bad news. Okay, and she's looking just for the nurse. She looks a little uncomfortable. She grimaces at times. So Shoshana is Dr. Hellman is the new attending. It's her first day on service, which is how this case actually arose. A new attending, never been attending before, first day on service, and here's the case he's presented with. And everybody thinks that this lady can't survive, and that they've done the best they can with the time-limited trial. It's another phenomenon, actually, to think about in family meetings, especially if there's a lot of conflict. Well, let's try this. You don't feel like she's been given a fair trial. Let's try this for 2 days. Or maybe your plan. This looks very serious about Mrs. Duncan as she comes into the hospital, but I think we should give it a try. Let's intubate her. I kind of am pessimistic it's going to work, but let's try it for a few days and see where things go. Time-limited trial, but being clear that you're not going to do this forever. All righty, so this is not the ideal way of sitting in a family meeting, but it's an ideal way for doing it, a role play here. And I'm having a little second thought here. Shoshana took our 2-week course in faculty development. She's a nice person. I don't want to, this is just a role play, but I don't want to put her in a position where she feels like she didn't do a good job and where the audience is sort of booing or falling asleep or something like that. I mean, that would not be the kind of thing a friend would do, right? Or any teacher. You don't want to shame somebody, okay? So I'm just thinking, before she starts, let's write some things on the board that she ought to remember. I mean, let's just sort of let's have a roadmap. 1, 2, 3, 4, 5, that kind of thing, about what she should do. And then, she can write it on her sleeve, or if all of a sudden things get sort of like, where am I? I don't know what to do. Let me out of here. She'll have a nice list up here of things to do. So let's help her out here. What would be the first thing?
Establish the setting.
Okay, establish the setting. What was the next one? Introduce. Okay, so setting. You've probably all been exposed to some Breaking Bad news teaching. That's kind of become fairly standard. And these are the kinds of things you talk about. Yeah.
We still listen to what's not being said.
Okay. Let's see. I'm not going to put that next, but listen and including what's not said. You going to be able to read this, Shoshana? Good. Okay. All righty. Give me some more things that she should think about. It's just like a roadmap. How do you get through a meeting?
She should, in thinking about setting, also prepare and know all the medical facts, understand what the other teams, where they're at.
Oh, okay. So there should be kind of like an agenda and a preparation so that when the nephrologist walks in, he doesn't say, "Oh, things are going really great. Let's rev up the dialysis machine and we'll get her out. We'll get her through this." Right? That's the kind of thing you're talking about. And that everybody has a general understanding of the prognosis. These two haven't talked happily, so maybe we'll cause some confusion. Yeah, and actually, one of the things about ICUs and hospitals in general, the family comes in, let's say, at 7 o'clock, and the intern's there, and the intern says, "Oh, it's been a really good night. The propofol went from 100 to 95. Hope springs eternal. She slept through the night." That is, the intern slept through the night. And then the nurse goes in with the nurse, and the nurse has this sort of sour face and sort of like doesn't want to talk about things because you get a feeling things are really terrible. And then, they call up at 7 at night and they speak to... Communication is very confused in these sort of settings, and it's pretty easy to get mixed messages, and it's very easy to pick the ones that you like, both the people you like and the messages that you like. But anyway, so so they've all gotten together, they've talked about it, they're prepared, they know what they want to do, they've made a nice room here and turned off their beepers, and they don't introduce each other. Let's just assume you know each other when we do the role play. Okay, but give the poor lady a little help here. What is she supposed to do? Yes?
Ask what do they understand about the disease, what might be happening next.
Great. So, first rule of communication, try to understand what that other person is about. So, if they say, "Oh, she's doing great. Do you think we can take her home at the end of the week?" You've got a different situation than they say, "I can't believe that you're flagellating our mother in this way." So that's always the rule. Try to understand what's going on with them, what they've been told, and the next thing you listen, both what's said and what's not said. What do you do with everything? Okay, then you kind of summarize and educate. I'm getting worried about time, so I'm going to go on to the next thing, which I think is one of the major teaching points, at least at our hospital, and in the course where people come from all over. People tend to ask, now that we all understand each other, blah, 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 and we understand what the prognosis is, and et cetera, what do you think we should do? And what I would beg you to do is not to ask that question. And I think it puts a very unfair burden on the family. This is not, what I'm saying is not 100% accepted everywhere, but I think clearly the first question is, what would mom want? Substituted judgment. Okay? The family's the expert on what the patient would want if the patient could speak for herself. You are the expert on what's realistic and how to meet those values and goals that the patient has. And so, I'm I'm kind of moving along a little quickly, but substituted judgment. What would Mom want if she can speak about this? And then that's going to lead to a recommendation rather than a question. And it's going to sound, we won't get this far in the role play. It's going to sound something like this. Now that we've all talked about what's going on and we understand Mrs. Duncan's situation and what she would want in a situation like this, and incidentally, we don't really have much choice in this situation. The loving thing to do, or you might say the ethical thing to do, or the right thing to do, the respectful thing to do, is to extubate her, take her off the ventilator, and let her die peacefully. And then you talk about what the family would want, and timing and place, and a whole bunch of other things to do a really good, humane extubation. And then, obviously, how do you feel about that? What are your thoughts? They can disagree, but this is what I would call assent rather than consent. Think about that one. I think that's the right way to do it in most cases. Okay, so let's do a quick role play, and we'll take maybe, I don't know, 5 minutes, and then we'll stop it and ask people how it went and have some observations, and then I'll try to summarize. You can actually put I don't think Shoshana needs this. You can put the screen down when you have a chance. Okay, fire away. Speak loud.
Can you guys hear me okay? So thank you everybody for coming. I know some of you traveled far and it's been a long haul. Mrs. Duncan has been sick for a very long time. This is my first day on the service, and I don't know if you've met Tom, the nurse, but thank you for coming. Just wanted to start by asking how you're all feeling and what you know about your wife's condition, your mom's condition, and anything you want to share with me first.
Well, we're doing okay. I mean, we know this is tough, but I think we're holding up, doing the best we can. I don't know what's going on.
Me either. I had no idea she would end up in the hospital.
You haven't said anything to us this whole time.
We told you your mom was sick. You knew she's been sick. She didn't want to worry you guys though, because we wanted you to be able to focus on your studies, not worry about it.
Can I ask how she's been doing in the ICU?
Yeah, I'm definitely going to get to answer all of those questions. It's very critical. I'm just getting a sense that it's time for me to give more detailed information if that's okay with you all, and I think you're both of an age that you can hear some of these things. Before I share what we think from a medical perspective, I want to know what the doctors have told you and the nurses have told you before today, get an understanding of what you think is happening with your wife.
Sure. So, we know she has cancer, and she's been getting treatment for it. She went through a couple cycles, and recently she's been getting some experimental treatment. Her oncologist told us that we'd see how this worked, and she seemed to be doing okay at home, and then a week or two ago she got kind of turned yellow and she started having pain in her stomach and throwing up. So we brought her to the hospital, and she's been here since then.
Has anybody ever told you whether or not the cancer was curable?
Well, they told us that it wasn't curable, but they said it was treatable.
What did you take that to mean?
Well, we thought we thought we'd have some time. We knew that her time was limited, but you know, we thought, well, she'll get treatment, she'll be okay for a while, and she'll get past this, and then, I mean, we knew eventually things would go downhill, but we were expecting, you know, that she'd do okay for a while.
Is this new information for the two of you?
Yeah.
Is it?
Well, I've been at home, but I really didn't realize that she would end up in the hospital and she would be so sick.
Well, I mean, I don't think any of us thought she'd end up in the hospital this sick. You know, I mean, we thought she'd do okay, and we didn't want these guys to be worried about her.
I think that's really natural, and I can respect how hard it is to talk about these things or to prepare for something like this. I'm wondering if your wife ever shared with you any of her fears about the future. When she got her cancer diagnosis, did you talk at all about the what ifs?
No, she just said, you know, she's a fighter. She's a tough woman. She raised our two kids pretty much by herself because I was busy working. She just said, we'll get through this. And we never talked about what might happen, and you know, she got sick like this.
And she got all the best treatment. The oncologist gave her everything.
She's been going to Stanford.
I mean, there's always great stuff.
Yeah.
I don't know. I keep hearing about all this good stuff happening at Stanford. I want to go there one day. They gave her everything?
I mean, they gave her, I don't know. I mean, her oncologist seems to be really good. You know, he's listed in the, you know, that Who's Who book and of doctors, and he's got all these titles after his name. He's like the head of this cancer institute. So who else could? She got to get the best treatment, right?
I did review your mom's chart, and it does look like she's gotten excellent treatment. But I hear what you're saying, which may be a little bit larger than the question of the treatment that she's gotten, and it feels a little bit like hard to hold on to the possibility that your mom might not do well even with the best treatment. It looks like she's so sick, and in fact she is. And
Well, I'd like to share something. I know I live far away, but my sister and I are very close, and she's been trying. She loves you all so much, and she just wants to protect you, but she's told me that she'd be willing to go through a lot really for you all.
Trouble hearing.
Yeah.
She'd be willing to go through a lot for you all, and I think she has, but she's actually been clear to me, and she tells me that if the situation were hopeless, that's her words, she wouldn't want to be on machines for the rest of her life. And
Let's stop there. I mean, you can see where it might go or where it might not go. And thank you very much. Oh! Don't get up quite yet, though. So, to do feedback, getting back to this sort of notion of reflection, usually what you do is you start with the person who's in the hot seat and say, well, how did it go? How did it go?
okay, but somewhat artificial. I was concerned about time. I've never had to do a family meeting in 5 minutes before. But and artificial in the sense that I don't know the patient well enough. So really, you know, I feel like I'm winging it more than usual. So.
Yeah. Anything you thought went well or didn't go well?
I liked noticing the piece about what was underneath the desire for the best treatment. Being able to maybe bring that to the surface. That was the way I felt less stressed.
Yeah. You've done everything that you could have done, or we did everything we could have done. It's important. Let me ask the husband, or the family is okay. By the way, you notice how much the nurse talked? This is a very good experience to be the nurse in this role play, because the nurse hardly ever talks. And yet the nurse has to be there. The nurse is the one who knows the patient the best in the most intimate way, usually. And especially when issues about suffering come up, the nurse is the one who's got the words. So we have a rule that you have to have the nurse at the family meeting. And it's also for protection of the interns, because they would scratch his eyes out if he or she didn't get invited. Anyway, so there's a time to call on the nurse. Any response from the family? Any comments about what worked or didn't work, or how you felt? Or?
I wasn't so worried about what the doctor was saying as the two children, and I'm thinking, maybe I don't want them here to hear all of this.
Yeah, good dad, protecting his kids. Not what I would call the right instinct, but also very normal and lovely instinct. Yeah. The kids were a little, were out of place, and I guess you could argue, do we need to do a lot of family therapy here? You probably don't need it. There's obviously conflict, but if they're loving, get along sort of people, they're probably going to do okay. The sister provided the substitute judgment. So Shoshana is now in a position to say the right thing to do, loving thing to do. That she, everything's been done. She cannot survive. You might want to say she's going to die. I think using something very concrete, die, dead, not survive, whatever. And now let's talk about how to do this in the way that's most respectful of your feelings and Mrs. Huffman. Okay, so I will give a few comments, and then I'm going to turn it over to you. I thought, the most obvious thing, which I think is probably true of most of you, is that Shoshana was just nice. She was just a nice, caring person. I would like her to be the one talking to me in that situation. And, she said, thank you, it's been a long haul, and a lot of empathic comments. How are you feeling? About sharing. How are you doing? There was that really, I always learn things from these role plays. She said, did you think were you told it was curable? It wasn't like saying it was hopeless. It was like, trying to explore very gently what they had been told. And she sort of addressed the fact that it's a shock. I don't remember the words, but he was saying it was a shock. And one of the weird things, I mostly deal with cancer patients, is this is a disease where, the survive, when they refer to me, very rarely do they survive. And yet, when people find out it's the end, they're shocked. So that's human nature. And then the thing that I wrote down is the what ifs. I thought that was a nice way to ask, I usually say, I wonder if you had also thought about things not working out well. Anyway, what ifs. And she just provided a lot of reassurance and holding this family. Anyway, those are the things that I noticed. How about you? Please.
As an ICU nurse, in these meetings, we're waiting for the death word to come up sooner than at the end of the conversation. And usually by the time these meetings are held, we wish that they were 2 weeks, 3 weeks earlier. And so emotionally, when we go into these meetings, we're holding back.
Yeah.
We are really holding back. And Shoshana's way of being the velvet hammer is awesome, but in our attitudes as ICU nurses, we're much more, this patient needed to die 2 weeks ago. So just.
Well, this is day 3. Give her.
Oh, yeah, right.
Give her a break.
But in reality, a lot of these
Yeah.
conversations really happen way too late. In our opinion, in
Yeah.
my opinion.
No, that's
So I just
uni-
want
that's
the
universal.
docs to realize how we are holding back what we're really doing.
Universal phenomena in intensive care units. Very hard on the doctors, I should say, also, because of the tension. And there are lots of ways and structures to address that so that people are working more smoothly together. And I would say it's partly the nurses understanding what the doctors are going through and the doctors understanding what the nurses are going through. I sound like a family therapist. At any rate, but I can't, anyway, I'm not going to deal with that here. Go ahead. But thank you for bringing it up, please.
So for the substituted judgment, what I really like to do is make it very general, not which she wants to be taken off the ventilator, which she wants another day of antibiotics, but more getting it on to very general quality of life, comfort.
Great.
And they all then will hang on to that. And then we can much easier go into the second part, which is, then I have a recommendation for that.
The line for that is, we don't talk about procedures, we talk about goals and values. That's what the family knows about and understands. And there are all kinds of people in this world, but most people, and I only say most, are concerned with survival, quality of life, functional status. It's sort of in that category. Those are the ones that we tend to think about too. There are a few other categories, but that's where the family can really come in. It's not, you think we should increase the pressures. Give me a break. Okay. Please, in the far back.
I thought she did a really nice job of turning the tide when the kids were saying that you get the best care, and so that was kind of taking a different turn. And she said, what's it like to think about that you could receive the best care possible, but not always have the outcome you want, or whatever your words were. And what that did was reassured them, grounded them in reality, and changed the course of the conversation.
Yeah, it was great. Little turnaround. I think the husband used the word fighter, which at least in our ICU tends to make the hair stand on the back of people's heads. But the point is, we are fighters. That's what the intensive care unit is about. That's what we are as doctors, that we're fighting for our patients. So when somebody says fighter, I say this is kind of like what at least used to be called jujitsu. Yeah, we are fighters. We're fighting, and we've done everything we can. And you're a fighter, and we're a fighter, and you've done the right things. But okay, I think what I'd like to do is show a few kind of summary slides. Is that right? Oh, thank you. Thank you. So just to recapitulate, again, it's good to hear things 2 or 3 times in different ways. Prepare for the family meeting. Make sure everybody knows what's right, what's going on. Who you invite can be an important thing. Has the chaplain had contact with this family? Maybe the chaplain should be there as their own spiritual advisor. Introduce. It's amazing how often that isn't done, at least in our ICU. People are embarrassed to ask about who each other are. Assess understanding. Understanding is where you begin, and it includes a lot of things. I also am interested in how, whether people really want to get involved with a decision, how much information they want, how they think decisions should be made. You may or may not be familiar. Well, the studies were done largely in Korean Americans and in Navajo, but many people really think if you talk about it, it's going to happen, so don't talk about death or whatever. Listen, listen, listen. Summarize, educate. Again, I think you need to use the death, dying, the D words. Then substituted judgment. What would Mrs. Duncan want? Explain what you're asking the family. You are the experts. in what she would want, but not in how to achieve those goals. We're doing the loving thing. What's it like to hear all this? And here are my recommendations. Based on what you told me, this is what I think we should do. It's not a menu. And we always care. Don't say we're going to remove care. We always continue to care for our patients. But caring may mean withholding and so on. Plan for follow-up. Debrief, document, and communicate. Again, this business about the difficulty of communicating in an ICU. It's important that what the meeting is documented or explained to everybody on the team, so that we're all on the same wavelength. The brief is about what we did. You know, hey, Shoshana, how did it go? And remember about sort of reflective practice. The chance for Shoshana, let's say, to speak to the nurse and vice versa, and say, well, what went well, what didn't go well. The nurse is the second set of eyes. You know, did you see how angry so-and-so was? Or anything can be very, very helpful. And that's